Hi guys, welcome to the session where we'll be talking about distribution. See, before going into that, shall we do some small experiments in it? Right. So, we'll take up this tea bag, and what I'm going to do is I'm going to put up this tea bag inside this water bottle. Yes. And we'll just close this. We'll use this water bottle later on, right? We'll open this water bottle after some time. Now, let's talk about distribution, guys. So, what exactly is distribution, which we have learned it from the previous ones? Distribution means movement of drug molecules from the blood into the tissues or organs, right? That's what distribution is. For understanding the basics of distribution, just consider. So, let's consider, I'm going to talk about a train, guys, right? So, consider this train has got around 5 compartments. None of the other compartments, the people cannot gain entry into the other compartments easily. They have to gain entry only into the first compartment. From the first compartment, they can move into the second, third, fourth or fifth, right? So, the entrance is going to be there only in compartment number 1. Every compartment has got 2 seats there. So, now we have 10 people who is gaining entry into the first compartment. 2 seats are there. 2 people will be sitting down in that train. The remaining 8 will move into the next compartment in search of seats to sit down. The second compartment, 2 seats will be there, 2 people will be sitting down, 6 will move into the third one, 2 will be sitting down, 4 will move into the fourth one, 2 will be sitting down, 2 will move into the last one, and last 2 will be sitting down in the last compartment. A basic logical one, right? So, this is our daily practices, and why are we using it in pharmacology? This is what exactly happens whenever a drug is been administered into the human body, guys. So, if we have come now into a distribution means now the drug has gained entry into the blood, right? So, take out your eyes from the site of administration and put it up into the blood. Now, we are inside the blood now we are inside the blood vessels. From the blood vessels, how we are going to move into the target tissues? Or else from the blood or from the plasma, how we are moving inside the RBCs or WBCs or nearby cells or any other cells, any other tissues or organs for the same. So, here what happens is we have given the first set of drug into the blood, right? The first compartment. It binds with certain proteins which is there in the first compartment, and the remaining drug which are free tend to move into the next compartment. There it binds with particular proteins, and those drugs which are free will move into the next compartment. There it will bind with certain proteins. So, from this we can clearly take up that those drug molecules which are bound with the proteins is not going to be moving out. Only those drug molecules which are free tend to move from one compartment to one another compartment. Is that clear? If that point is clear, you can understand one major issue, and that is one major point, and that is nothing but the concept of distribution, right? So, from this we can clearly note that free drugs will bind with plasma proteins and tend to produce drug protein complex. Free drugs are the one which is going to move from one area to one another area, which means free drugs are the active forms. Whereas, on the other hand, the other side of the equation, we have the bound forms, drug protein complex. These are the inactive forms because these are bound with the plasma proteins. So, we have the proteins which is there, plasma will be called as plasma proteins. Those proteins which is there in the cells will be called as cellular proteins, or it might be the target proteins, we do not know. These proteins might be the target proteins for because many different drugs are there, right? As the free drug molecule, if it is free, it is going to be active. When it is binding with the plasma protein, it is converted to an inactive one. That is the reason why these plasma proteins are also called as silent receptors, because it is also binding with proteins, but it is not producing any response. That is why it is called as a silent receptor. The other name of the plasma proteins are site of loss. Site of loss means here the drug is binding with the protein, but because of the binding, the action of the drug is compromised. That is why it is also called as site of loss. We also have one more terminology for explaining plasma proteins, and that is drug acceptors. These plasma proteins tend to accept the drug molecule, and it is going to be just there. It is not going to be producing any of the responses which we have expected before. So, from this we can clearly say, if a drug is been administered via intravenous route, how will be the graph, guys? So, consider again, here is where the y-axis is and here is where the x-axis is. On the y-axis we have plasma concentration of the drug, and on the x-axis we have time. When it is given via intravenous route, where the graph is going to start from? Is it going to start from 0 No, right? It's going to start from the top, right? So from there, the drug is going to be constantly removed out, right? But it is not going to be a uniform decrease. It is going to be, first there is going to be a rapid decrease in the size of the graph, followed by a gradual decrease in the size of the graph. The rapid decrease in the graph is because of distribution, which means if you have administered 100 milligram to a patient via intravenous route, all the drug will get moved into the tissues and get deposited there. Majority will get deposited over there. Only minority will be there in the blood. That's the reason why suddenly there is going to be a deep fall in the plasma concentration of the drug. After some period of time, because of slow metabolism and slow excretion, there is going to be a gradual fall in the level of drug in the blood. Right? So please make sure it's an important question, guys. The reason for rapid decrease in the plasma concentration time plot when a drug is given via intravenous route is due to distribution. Please remember that. Now, let's talk some classical features on this plasma protein binding, guys. Right? What about these plasma proteins? What are the different plasma proteins which we have? Plasma proteins might be of many different types, but the most important one comes under two major umbrella. The first one is called as albumin, and the next one is alpha-1 acid glycoprotein. Majority of the acidic drugs will bind with albumin. Majority of the basic drugs will bind with alpha-1 acid glycoprotein. This is what we can see whenever this image is not zoomed. When we just pinch in and zoom on this concept, we can understand one more concept, one more point, and that is albumin tend to bind not only with acidic drugs, it binds with both basic drugs and acidic drugs. But with the basic drugs, it is going to be binding with low affinity, whereas with acidic drugs, it is going to bind with high affinity. The affinity is going to be higher for acidic drugs, the affinity is going to be lower for basic drugs. But majority of the drug will bind with albumin, majority of the basic drugs will bind with albumin, which means albumin will bind with the basic drugs with a high capacity, whereas albumin will bind with the acidic drugs with a low capacity. Even though it is having low capacity binding with acidic drugs, that bond is going to be an extreme stronger one. It has got a higher affinity with those drugs. Clear? Now, what are the different classical features of a drug with high plasma protein binding? It has got three major features, guys. The first one is it tends to produce more amount of drug interaction. If a drug is been designed, if a drug has been explained as a drug with high plasma protein binding, it means what? It means this drug has got a high drug interaction, for point number one. The second point, it tends to have more duration of action, and it tends to have a lesser volume of distribution. We'll be talking about that, don't worry. First, let's concentrate on the increased drug interaction. The increased drug interaction is because of a basic phenomena, guys, right? Consider I have this particular protein. This is a protein which is there in the blood, guys. This is a plasma protein. Consider I'm going to talk about an acidic drug binding. So for this example, I'm going to assume this as an albumin, right? For example, consider I'm going to administer the first acidic drug. This acidic drug will try to bind with this particular protein at different areas. It cannot bind with it. So it is going to bind with the only site where it can bind. Now this drug has bounded with this albumin, and the remaining drug is going to be free. Majority has been bonded, some is going to be free, and that is going to be producing the drug's effects. Now what happens is the patient is being treated with one more drug, and that drug, the patient has been treated with one more drug, and that drug also is being an acidic drug. This acidic drug has got still more stronger binding with this plasma protein. So what it does, it comes and just throws this drug out from this area, and as this has been thrown out, this drug tends to bind with this plasma protein. Clear? Now forget about this drug, guys. What was the plasma concentration of the first drug? Initially it was minimal, now more amount of drug is going to be free. This drug's concentration, free drug concentration, is increased up to a drastic level, leading on to adverse effects of this first drug. Now what I am going to say is, I am going to say names of these individual ones, simpler. Clear? Now consider I have this plasma protein, that is albumin. First drug if we administer is warfarin. What is warfarin, guys? It's an anticoagulant agent. It has got a high plasma protein binding. Warfarin is a weak acidic drug. It binds with the plasma protein. Only minimal amount is going to be free. That is going to be producing the anticoagulant effects. Now consider the same patient is complaining of some headache or any other complaints, and the patient has been treated with the second drug, and that drug is aspirin. This aspirin also is highly bounded with plasma proteins, but it has got more affinity with albumin than warfarin. Now, this will come and displace warfarin out from the area, and it is going to bind with the plasma protein. Now, what has happened to the plasma levels of warfarin? More free concentrations of warfarin tend to occur. Because of it, the patient will land up in adverse effects. Because of it, the patient will land up in high concentration toxicity of warfarin in that patient, which means the patient will land up in bleeding, a basic concept. This is what we call it as displacement reaction, guys. A classical interaction, a superb interaction which can be seen between warfarin and aspirin. That's what I have demoed it to you. The next one is increased duration of action. How come there is going to be increased duration of action? This increased duration of action is because whenever a drug is being free, it comes near the glomerular membrane, right? We all know that glomerular membrane, how the filtration tend to occur, guys. The filtration tend to occur not based on the penetration or non-penetration, not because on ionization or unionization. It is purely based on the size of the molecule, guys. Of course, in your home, you have made chapatis. If not, don't worry. For guys, if you have not get married, once you get married, you will be doing all the works in your home. No need to worry, right? Whenever you are in your home, while putting before chapatis, you will be having this floor, and you will be using a sieve to just clean off this floor, right? A similar concept is going to be there with the glomerular filtration. That sieve is the glomerular filtration. Smaller molecules will just pass through the glomerular membrane, gain entry into the urine. Larger molecules will not pass through the membrane, it remains back within the body. Smaller drug molecules are mostly smaller, guys. These smaller molecules can easily move through it, but when the drug molecule is bounded with the plasma protein, it cannot go through that. Clear? So, which means if a drug is highly plasma protein bound, it is not going to be filtered in the glomerulus, which means this drug is not excreted out from the body. The drug accumulates in the body, more duration of action. The second point, we are cleared of it. And the third one is volume of distribution. We will be talking about that in few minutes, guys. How volume of distribution is going to be affected and what are the different areas which is going to be involved in. Before going into this volume of distribution, we are going to see on certain factors in which the distribution is going to be dependent on. Distribution is dependent on two major factors. The first one is blood flow to the individual organs. See, when you take up the drug from the intestines moves into the blood. Absorption, we have completed that chapter, no need to worry. Now, the drug is there inside the blood, right? So, from the blood, we have many different organs in the body. From the brain, we have liver, kidney, muscle, skin, we have bone, fat, individual tissues, RBCs, many different areas are there. Where is it going to be moving at first? That's what an important issue, right? And that is dependent on the blood flow to the individual organs. So, the major organs which receives blood flow is BLK, right? That is brain, liver and kidney. That's going to be the most important organ where the drug is going to be distributed first. Followed by muscle and skin, followed by bone and fat or adipose tissue molecules. Clear? This is the ratio, this is the order in which the drug is going to get distributed. You have to remember this order. If you remember this order, it is easier, it is a cakewalk to understand redistribution. We will be talking about that after this topic, and that is volume of distribution. Now, coming towards the next dependent factor of distribution, and that is volume of distribution. What exactly is volume of distribution, guys? So, now here we are going to see about the first thing which we have done. We have taken up a plastic bottle with water and we have put up a tea bag and we have closed it, right? Now, we will take a look at it. So, guys, here is what the first thing which we have done previously. So, what we did was we just took up a bottle in around 100 ml of fluid. We just put up a tea bag and we closed the fluid, closed the bottle and we kept aside. In that, we can clearly see that the upper half, right, the upper half of that fluid, the tea molecule has not mixed here, whereas only the lower half of the fluid, the tea molecule has got mixed, which means out of this whole 100 ml, only the tea molecule has got mixed with the 50 ml of fluid which is there in that bottle, whereas the remaining 50 ml the drug molecule has or the tea molecule has not mixed with, which means what I am trying to say is the volume of distribution of this tea bag is 50 ml in this bottle. I hope this concept is clear. The similar thing we are going to apply to the human body. The volume of bodily fluid in which the drug molecule gets distributed, that will be called as volume of distribution. So, guys, what we have seen is a small demo of how a drug is going to get distributed within the body. So, from that the same we are going to apply it to the human body, guys. Volume of distribution means the volume of bodily fluid in which the drug is going to get distributed. The volume of bodily fluid includes your plasma, your pleural fluid, we have, if the patient is pregnant, we have amniotic fluid, then we have synovial fluid, all the different fluids which is there, ECF, ICF. The drug is going to get distributed to how much ml of bodily fluid, and that is what volume of distribution is. But this volume distribution has been termed as an apparent volume of distribution. Why? Why is it called as, not called as volume of distribution? Instead, it will be called as apparent volume of distribution. Why? Because we cannot actually calculate the volume of distribution of a drug, right, in a particular patient. So what we do is we always come up with the value in comparison with the drug which has got a higher volume of distribution. So which drug do we compare? We compare it with the digoxin, we compare it with chloroquine. These two drugs tend to have a higher volume of distribution. So compared to that, this drug has got, based on the values, we can say that this drug might be having this much volume of distribution. So everything is going to be an assumption. So we are going to put it up as a name as apparent volume of distribution. So how do we calculate it, guys? How do we calculate this? We calculate it with the formula amount of drug in the body divided by the concentration of drug in the plasma. Amount of drug in the body divided by concentration of drug in the plasma. How do we calculate the amount of drug in the body, guys? Simple, the amount of drug which has been administered to the human body, or dose administered. So volume of distribution is equal to dose administered or amount of drug in the body divided by the concentration of drug in the plasma. I am talking about the initial concentration of drug in the plasma, C0. Why? Because after some period of time, because of metabolism and because of excretion, the concentration of drug in the plasma tends to fall down, right? So that's the reason why we don't ever take the plasma concentration after 1 hour or after 5 minutes or after 10 minutes, no. Initial volume of distribution, immediately after administration of the drug, how much drug is going to be there in the plasma, only that we are going to take it up. So VD is equal to dose administered by plasma concentration or initial plasma concentration. So with that, we can also come up with one more formula for calculating the dose to be administered in a human being. If we have a drug, how much drug do we administer to the patient? We have to calculate it, right? We calculate it with the values of VD and initial plasma concentration. Is that clear? And also one more point is, we're going to talk about the relationships of volume of distribution with several other factors. Volume of distribution is directly proportional to the age. As the age increases, the volume of distribution tend to increase. Obesity, as the weight increases, the volume of distribution might increase. Lipid solubility of a drug. If a drug is highly lipid soluble, more volume of distribution tend to occur. Pregnancy, why? Because of increase in the blood volume by the end of 3rd trimester. And also because of amniotic fluid and because of extra additional compartment which we have. Fetus itself is a compartment, guys, according to our pharmacology. Because of it, the volume of distribution might be increasing. So volume distribution means basically more of the drug is accumulated in the tissues and less of the drug will be there in plasma. A classical point, most important points, please have that in your mind. If a drug is having more volume of distribution, it means what? More of the drug is there in the tissues, less is there in the plasma. Just give me a basic example, guys. Which drug is going to be excreted out from the body? I am putting that question in a different way. Which drug in the body is going to be eliminated by the kidney? Is it the drug which is there in the plasma, or is it the drug which is there in the tissues and the extracellular or in the intracellular fluid? Yeah, the drug which is there in the plasma, right? Because the kidney is filtering out only those drug which is there in the blood. So which means if a drug is more accumulated in the tissues and less is there in the plasma, it means only less amount of drug is going to get eliminated. Of course, everything is going to get eliminated, but it will take a longer time for the other drugs to get eliminated, and that's the reason why volume of distribution is directly proportional to the duration of action of that drug also. Which means a drug with high volume of distribution means it has got more duration of action also. At the same time, I have also told any factor which prevents the drug from moving into the tissues. I am repeating those words again. Any factor which prevents the drug from moving into the tissues from the plasma tend to decrease volume of distribution of that drug. One of the most important factor is plasma protein binding, right? This is actually a brainstorm, guys, right? Within 3 sentences, I have compiled all the things which I have said for half an hour, right? And that is, if a drug is highly plasma protein bound, that drug is going to be in the inactive form, bound in the inactive form. Only free drugs tend to move from one compartment to one another compartment. Bound form will remain within the plasma. If majority of the drug remains in the plasma, only minimal tend to move across the tissues, which means the volume of distribution of the drug is going to be lesser. Clear? So, volume of distribution is going to be inversely proportional to the plasma protein binding. This is applicable only based on the concept of VD and concept of plasma protein binding, guys. Right? Because on the other hand, we have already seen high plasma protein binding, high duration of action. High volume of distribution, also high duration of action, right. So, this volume of distribution is inversely proportional to plasma protein binding, is purely based on the concept of understanding of what exactly is VD and what exactly is plasma protein binding, my dear guys. So, a drug with high volume of distribution means much high concentration is going to be there in the extravascular tissues than in the plasma, right. For example, we have digoxin, right, the digoxin which has got a high volume of distribution. Majority is going to be stored in the skeletal muscles, right. This digoxin, to say, we used to call skeletal muscles as a reservoir of digoxin. So, we know that digoxin has got higher volume of distribution, that is based on the skeletal muscles. When the patient is older, they are going to have less muscle mass. If the muscle mass is lesser, this digoxin has got no space to get stored up. So, the volume of distribution will be decreased for digoxin, the first point. The next point, obese people. I told that volume of distribution is directly proportional to age and obesity, guys, and this is what is not going to be applicable for digoxin. That is what I am trying to explain right now. We told that VD is directly proportional to obesity. So, if we give digoxin to a patient who is obese, it does not mean like this patient tend to have more volume of distribution. Why? Because digoxin has got very least distribution towards adipose tissue. This does not enter the fatty tissues, it just enters the skeletal muscles. So, even if you give digoxin to a patient who is obese, it will not affect the volume of distribution of a patient. Is that clear? This is the take home point, guys. But on the other hand, for theophylline, the apparent volume of distribution is directly dependent on the body weight of the patient. As the body weight increases, the theophylline's volume of distribution also tend to increase. So, please have this basic knowledge on VD is directly proportional to age in all the conditions, but not especially in terms of digoxin, because as the age increases, the muscle mass decreases, volume of distribution tends to decrease. VD is directly proportional to obesity, but it is not applicable in digoxin. Why? Because the digoxin does not enter fatty tissues. So, even if the patient is obese, it is not going to be affecting the volume of distribution. Not only that, in terms of abnormal accumulation of fluid like ascites, we have edema, we have pleural effusion. In all of these conditions, the drug also has got another compartment where it might get mixed up, where it might get distributed to. This abnormal accumulation of fluids can also increase the volume of distribution of a drug. For example, gentamicin, the aminoglycoside agent, usually has got a very less volume of distribution. But when it is given in terms of abnormal fluid collections, its volume distribution might be increased, right. So, there is only one condition where gentamicins or aminoglycoside's volume of distribution can be increased, that is primarily because of abnormal fluid collections. Aminoglycosides are antibiotic agents, guys. Now, let us come towards the most important one, that is we have seen about two drugs which has got high volume of distribution. I hope you remember those. What are those? One with the D and the other one with the C. What is this? Digoxin, and digoxin is the drug which is used for congestive cardiac failure. The other one is chloroquine. Chloroquine is an anti-malarial agent. Apart from these two drugs, we have many other drugs which might have higher volume of distribution. What are those? So, the first one which we have is chloroquine. The second one, it can be remembered with the mnemonic amlodipines. Amlodipines. It's a mnemonic, guys. AM is for amphetamine. AM is also for amiodarone, amphetamine and amiodarone. LO is for LOL drugs, that is beta blockers. AMLO is for amlodipine. Amlodipine, do you remember one of the most famous trade names? We shouldn't be using trade names during the sessions, but amlodipine has got a famous trade name, and that is Amlong, right? Amlong, why is it called as Amlong? Because it has got a longer duration of action. Why is it having a longer duration of action? Because it has got a higher volume of distribution. Fantastic. Diazepines, so DI is for digoxin and diazepines is for benzodiazepines. Not only that, we also have organophosphorus compounds which also tend to have a higher volume of distribution, guys. But apart from this, we have to remember one basic point, and that is What exactly is dialysis? You know what is dialysis is, right? Dialysis means we're just giving it an artificial kidney space, right? We're just filtering out the drugs which is there in the blood. We are trying to replace the action of a kidney by giving some artificial infusions, by giving some artificial apparatuses where we can do what the kidney does. So what actually the kidney does, guys? The kidney excretes out what all the drugs molecules which are smaller in size or free drug molecules. And if it is plasma protein bound, it is not going to do. That's what the kidney does. That's what the filtration is actually happening. So dialysis is going to be effective. Dialysis is going to be effective in treating a patient who has landed up in poisoning of a drug which has got less volume of distribution, less plasma protein binding. This statement is an important statement. Please have that in mind, guys. We are just trying to put the clinical relevance of what all different things which we have in our mind. So if a drug is going to be, what if a drug is going to be highly plasma protein bound? If a drug is highly plasma protein bound, around 98 or 99% is bound with plasma proteins. Only 1% is going to be free. Only that is going to be removed out by dialysis. If a patient lands up in poisoning of that drug, and if you put the patient in dialysis, you have took the wrong step in treatment of that patient. And the same concept will be applicable for a drug with high volume of distribution. High volume of distribution means the drug is accumulated in the tissues, only minimal will be there in the plasma. If you put dialysis in those patients who has landed up in poisoning of those kind of drugs, what will happen, guys? The drug will not get excreted out. Majority will be stored in the tissues. It will take a longer time for that drug to be excreted out, which means we have took the wrong step. For example, the drug with high plasma protein binding, for example, what we have warfarin, we have seen that, remember, warfarin, we have aspirin. Or drug with high volume of distribution, we have digoxin, we have chloroquine. If a patient lands up in poisoning of warfarin or aspirin or digoxin or chloroquine, we cannot use dialysis in that treatment, guys, because it's purely beautiful pharmacology which we have. Apart from that, we have to know, okay sir, these are the different drugs with which we shouldn't do. For which drugs we have to use dialysis, right? We have, what are the list of medications with which we have to use dialysis for that? That's the mnemonic, guys. List med is the mnemonic for remembering the drugs for which we have to use dialysis. List med. L is for lithium, I is for isoniazid, S is for salicylates, T is for theophylline or caffeine, M is for methanol, E is for ethylene glycol, and D is for divalproics or valproic acid. But here we have seen salicylates here, right? Aspirin, right? So we just now told that for aspirin poisoning, we cannot use dialysis because it's not going to be the particular treatment. But it has been clearly established, right? Aspirin poisoning, we can use hemodialysis in that treatment, especially because this dialysis tend to correct the fluid and electrolyte imbalances more than how it is going to remove the salicylates from the body. Yes, we can use, but it has got many other uses in treatment of salicylates poisoning. That's why we can use dialysis in terms of aspirin poisoning, guys. Clear? Coming towards the last topic in terms of distribution, and that is called as redistribution. For understanding redistribution, I need to have a, again, like how we have used train before, now we are going to use a bus, simple one. So consider you just go inside a bus. Your favorite seat is the seat which is immediately behind the driver, right? Behind the driver we have a small seat, right? Consider this is your favorite seat. But you couldn't get that seat because that seat is not empty. Instead, only the last seat is empty. You just go inside, sit up in the last seat and wait for some time. And after 1 or 2 stops, some people from the middle get down. You move out from the last seat, sit in the middle area. And after around 2 or 3 stops, the person who is sitting behind the driver gets down, that seat gets empty, you from the middle just move into and just sit on the seat in which you want to be sitting down. This is what exactly happens in terms of a human body, and that is what redistribution is, guys. Clear? Which means whenever you administer a drug which is going to be a highly lipid-soluble molecule, this molecule gains entry into the blood. Now from the blood, where it is going to be moving up at first, as you have already told, based on the blood flow, right? The organ which receives maximum blood flow is what? Brain, liver and kidney. The drug is distributed over there. But that drug is going to be highly lipid soluble and it is not going to be moving up. This drug is going to be having high tissue binding, so it is going to be binding up with the brain, liver and kidney. But as the drug concentration moves into the brain, liver and kidney, the concentration in the plasma tends to fall down. The equilibrium gets mismatched, so In order to maintain the equilibrium, the drug from the brain, liver and kidney just tends to move into the blood to maintain the equilibrium. Now, the equilibrium is attained, but these drug molecules which is there in the blood cannot remain in blood because these are highly lipid soluble in nature. It cannot cross the equilibrium and move into the brain, liver and kidney. So, what it does, it moves into the next most higher blood flow receiving area, and what are those? Muscle. It just moves into the muscle and skin, right? As the concentration moves into the muscle and skin, majority of the drug as it is moving into the muscle and skin, the concentration in the plasma again tends to fall down. So, what will happen? Equilibrium tends to be mismatched. The drug from the brain, liver and kidney still more will move into the plasma to maintain the equilibrium. Again, this drug molecule cannot cross the equilibrium, so it moves into the muscles and tissue, muscles and skin. Again, the concentration in plasma fall down. Again, the drug molecule from the brain, liver and kidney will move into the blood to maintain the equilibrium. Which means what we are seeing right now is what? We have administered the drug accumulates in the brain and it is moving into the plasma, into the muscle. From the brain, it moves into the plasma, into the muscle, into the plasma, into the muscle. This is what we explain it as redistribution. Here comes the most important question, guys. Among all these things, which is specifically called as redistribution? Is it the movement of drug molecule from the brain into the blood or movement of drug molecule from the blood into the muscle and tissue? Among these two, because in those two areas the drug is crossing biomembrane, right? Which is called as redistribution. Distribution means what? Movement of drug molecules from the blood into the tissues or organs, right? So, the movement of drug from the blood into the muscle and tissue, that property will be called as redistribution. Of course, the whole concept is called as redistribution, but that is specifically can be explained as redistribution, guys. So, if you want to put it up in a flow chart, here we can see the drug is going to be administered. After administration, the drug gets absorbed. It gets distributed to the brain, liver and kidney. It attains an equilibrium. But due to high volume of distribution and also high tissue binding capacity, the drug gets distributed to the muscles and skin. The plasma drug tends to distribute to the muscles and skin. Because of it, the plasma concentration tends to fall down. The drug moves from the brain, liver and kidney to the blood, to the muscles and skin. This concept is called as redistribution, for which drug tend to produce this beautiful response, and that is thiopentone, guys. Thiopentone sodium is a type of a barbiturate. Not only that, in certain conditions, even diazepam and nitrazepam also tend to produce this response. So, what is the primary mechanism of termination of action of thiopentone sodium and its action, guys? Thiopentone sodium's action is going to be terminated by what? Before that, we need to know what exactly is thiopentone sodium's action, right? Thiopentone sodium is a barbiturate. It behaves as a sedative hypnotic. So, before that, what exactly is thiopentone sodium, right? Thiopentone sodium is a sedative hypnotic. Its primary action is in the brain, guys, right? So, this thiopentone sodium needs to be accumulated in brain, but this redistribution is preventing it from accumulating in brain. Is that right? So, because majority of the drug is moving into the muscle and tissue, the drug from the brain is being removed out. The drug is prevented from getting accumulated in the brain, and that's also one of the reason. What is the reason for termination of action of thiopentone sodium? It's both redistribution and metabolism. Is that clear? Now we have one more concept called the selective distribution. What is the selective distribution, guys? Selective distribution means certain drugs tend to be distributed only to a particular area in the human body. Not only to the particular, majority will be accumulated in a particular area in the human body. Example, we have phenothiazines and chloroquine. Phenothiazines and chloroquine tend to bind with melanin containing tissue, especially in terms of retina. Phenothiazines are actually antipsychotic agents. Phenothiazines and chloroquine tend to produce retinal deformities. Visual disturbances can be expected with these different drugs. We will be talking more about that. When you talk about individual drugs, you will know, yeah, it is producing this response. Why? Because of this selective distribution. And also we have iodine. Iodine tend to be accumulating more, everyone knows, thyroid, right? Because we have a separate iodide transporter which is situated on the surface of the follicular cells. That is going to be transporting the iodine into the follicular cells, guys. So, from this, what we have seen as a small recap, guys, we have seen about what exactly is distribution, how the drug is getting distributed. We have seen about what are the differences between free drug and bound drug. We have seen about what's the classical features of plasma protein binding, the features of high plasma protein binding. Then we have seen a demo of volume of distribution and the features of high volume of distribution. Then we have seen about dependent factors, blood flow. Then we have explained about the redistribution. Then we have seen about selective distribution. Now, The last question which we have is, see, we have thiopentone and pentobarbital. Both drugs tend to have high lipid soluble agents. These are very highly lipid soluble drug, right? But if it is a highly lipid soluble agents, how they are going to get excreted out from the body? This much high lipid solubility, how it is going to get excreted out? That excretion is primarily based on a concept called as biotransformation, also termed as metabolism, which is the next topic under this classification, guys. Thank you so much.